Okay, we are live. Welcome, everyone. We're excited to have you for today's session of Understanding Your Melanoma Diagnosis. This is the second webinar in our series. You can check out all of the recordings on our website when you have a chance. But today we're here with Dr. Govind Warrier, MD, MPH, Assistant Professor of Oncology and member of the Melanoma and Cancer Immunology programs at Johns Hopkins University, as well as Cheryl Stratos, who joined us last time, our Chief Patient Advocate at 1104 Health. I'm going to pop up a quick poll. This is not going to be shared with the group. It's, anonymous to everyone, but it's really just to help us get a sense for where everyone's at in their journey, give us some context so that we can best support you. So if you have a minute, please quickly fill out that poll. And then as we go through the session, you can use the chat Q&A function to ask any questions as they come up. We'll try and answer them throughout, but we'll probably save most of them for the end. And we promise we will get to them either in this webinar live or as a follow-up.
Well, Shannon, thank you for the introduction. We're excited to get this day or this session rolling with Dr. Govind. We know you're completely well equipped to lead this discussion and help us discover how important the pathology is and understanding our kind of path forward with our melanoma diagnosis.
Yeah, thank you so much, Shannon and Cheryl, for the kind introduction. And it's really my privilege to be here with you all today. Just to round out what Shannon and Cheryl said, my name is Govind Warrior, and I'm a melanoma oncologist working at Johns Hopkins University. Specifically, I'm a medical oncologist, meaning I specialize in medical treatments for high risk and advanced skin cancers, of which melanoma is my primary focus. I spend a couple of days a week in clinic, caring closely for patients and collaborating with community partners to help them care for their patients as well. In addition to that, I work with my colleagues and mentors here at Johns Hopkins to develop cutting-edge studies to move the needle forward for patients with melanoma as well. So again, my pleasure to be here with you all today.
Well, we're really excited, and I don't know if you folks that are joining us today, if you've just been diagnosed with melanoma, or if you're in the kind of throes of treatment. We're here today to kind of let you know that we want to be a resource. The melanoma treatment landscape has changed considerably over the past 10 years. Up until that point, there hadn't been any real progression in treatment options for about 25 years. But with all those exciting new treatment options comes a lot of confusion and wondering why and what's going to be better for my melanoma. So that's really what we want to uncover today. And as we all know, you're not alone. More than 1.4 million patients are living with melanoma right now. There's just a lot of new options and hope that we want you to be aware of. Melanoma is also one of the fastest growing cancers in the United States and affecting a large majority of young adults, as well as white males over the age of 50. And we want to kind of start to, allow you to have a brief understanding of what are some of the questions you need to ask when you're with your oncologist, and give you a little bit of a toolkit, some things to consider when discovering how and where to get treated with your melanoma. So I'm going to turn this over to Govind and give him an opportunity to kind of start with some of the basics. What is melanoma, and kind of taking us through your early diagnosis. What do all these things mean, and into discovering your pathology.
Great, thank you so much for that excellent introduction, Cheryl. So taking a couple of steps back, melanoma is a serious form of skin cancer, one of many different types of skin cancers that we see in medical oncology. Other common ones may include things like basal cell carcinoma, cutaneous squamous cell carcinoma, and a couple other more rare types like Merkel cell carcinoma. But we've long considered melanoma sort of one of the most serious and frankly most deadly skin cancers. And it was this way, especially as Cheryl alluded to, in decades prior, before we had more effective treatments available. Cheryl, the comment you made about the dynamic nature of the landscape, that was something that I sort of lived even as I was coming through my medical training. There was very active discovery and innovation going on. And the landscape has changed even just in the period that I've gone through training, and certainly continues to remain dynamic. But therein lies, what I want to highlight is what you said, hope for patients with melanoma. And one of the things I start out by telling my patients that I see is, regardless of what stage, regardless of what setting that we're starting this journey together on, there's something that we can do, and there's hope moving forward. And I think that along with that hope comes complexity, right? As treatment landscapes change, then there suddenly becomes much more nuance in terms of how should we approach this in this place and time? What is the most appropriate thing in a collaborative decision-making way for the patient that's sitting in front of me? And then what's next, right? What is on the horizon that we should keep in our minds so that we're not leaving any stones unturned in terms of considering options for all of our patients. So that's a broad way of responding to your statement of, yes, this is indeed an extremely dynamic time in melanoma, and I think exemplifies the importance of making sure there's a well-informed team, and that you all as patients or caregivers are informed about what's out there as well.
And as
Great.
context for this as well, based on the pre-poll questions, all of our attendees have received some sort of medical treatment, and about 50% are currently in the process of determining a treatment path. And then we are all over the spectrum in terms of current familiarity with the treatment options.
That's great to know, and frankly, if you were to talk to even other providers, that you'd probably get similar answers in terms of familiarity with melanoma treatments. I'd add that Cheryl brought some really nice statistics. It turns out that in the United States every year there were roughly 100,000 patients diagnosed with melanoma, give or take, and a majority of those patients may be presenting at a relatively early stage. So if we think about the spectrum of melanoma, I sort of think about them on one end of the spectrum, your stage 1. Those are the patients. You may be familiar with the typical paradigm of someone has a very localized melanoma that's contained to their skin. They have some sort of an excisional procedure done, and then that's the end of the story. The other end of the spectrum, it's actually roughly about 5 to 10% of cases are those that present at, unfortunately, a stage 4 situation, meaning the melanoma has found its way to one or multiple areas around the body beyond where it started. And in fact, about 10 to 15% of the time, in patients who develop metastatic or locally advanced disease, we never find a primary skin spot. And that's not altogether too uncommon either. So I say all that to say melanoma comes in many different shapes and forms. We meet people where they are, and recognizing, one person's journey may look very different, or one person is starting may look very different. And I suspect, some of those on the call have lived that as well. So, therein again lies some nuance in terms of how to forge, an informed and safe path forward.
So there is no one size fits all as far as a diagnosis for melanoma.
That's right. I think it's very much, should be, and certainly is becoming increasingly very personalized decision making, taking into account some of those patient factors, of course, at the forefront, as I mentioned, and then many of the specifics of the melanoma now itself. And even we're getting now into the realm of sort of treatments themselves being personalized, which we can certainly touch on a little bit later as well.
Great. So when you're going through your overview, you just went through the overview of staging. Where does the genetic mutations come in?
Yeah, that's a great question. I'll take one more step back before answering your question, just to lay the ground for staging. So we broadly think about melanoma falling into a couple of categories among those stages. Those stage 1 and stage 2 patients, the staging is primarily dictated based on, a melanoma. Again, we're talking about cutaneous melanoma. This is different than ocular or uveal or choroidal, as you may hear it sometimes, melanoma. That's melanoma involving the eye. That's sort of a little bit separate entity. And, we can certainly touch on that if there's interest among the audience, but we'll focus on the cutaneous or skin form of melanoma for the moment. Among cutaneous or skin form of melanoma, among those stages, I sort of think about them as stage 1s, being the sort of lowest risk in the sense that they're the lowest risk to cause problems later. That doesn't mean that they can never cause problems later. They're just less likely to than the other stages. And the staging in melanoma is largely dictated based on how deep the melanoma goes actually from the surface of the skin. And the reason for that is the deeper and deeper you go into the skin, the closer and closer you get to things like blood vessels and lymphatic vessels, what I consider sort of the railroad tracks, by which melanoma can get around the body. And so the differentiating factor between a stage 1 melanoma and a stage 2 melanoma is largely how deep it goes. A stage 3 melanoma, on the other hand, denotes some level of local spread, meaning that it is spread to the lymph nodes in that area. Now, there can be any depth to which that melanoma went, but the fact would remain that it made its way to one or more lymph nodes, and that would be a stage 3 melanoma. And the stage 4 melanoma would be that it's made its way sort of more distant than the local close by lymph nodes as well. And so part of it is the treatment options and the follow-up and the types of surveillance that you do. All of that is very much dictated, of course, by the stage. Those that are stage 2 and higher, 2B and higher specifically, are higher risk cases, and so our paradigms for surveillance and treatment are a bit different than those that are in that 1 and 2A setting. Now, where does genetics come in? The reason I mention all of that is partially because the genetics can help inform potential treatment options, especially in those later stages, those stage 3 and above. And those could be your high risk cases that have already been treated with surgery, or they could be cases where things have spread, locally or regionally, meaning close by to the original site, but they cannot be surgically removed or treated with any local treatments. And the genetics may come into play there again in determining treatment options.
Oh, that was a great brief overview of the explanation. Well, so who, and just kind of, this is kind of back to basics so everybody's clear, who might be involved in your melanoma care through this whole process, whether you're, late stage or early stage as far as monitoring or moving forward with as a late stage patient?
Yeah, this is a great question. And there again, it depends a little bit on, of course, where the patient is coming from in terms of, their local, sort of how they came to attention with their melanoma, right? Sort of there again, thinking of two ends of the spectrum. One could be someone who, saw a dermatologist for a funny looking spot and they turned out to have an early stage melanoma. And that dermatologist ended up being, the really critical and really only person that was involved in that patient's care. So that could be as simple as a team looks. And that could have been a dermatologist, could be a surgeon, could be someone, whoever was doing that excisional procedure. But there are many others who could become involved along the way, and certainly would become involved early along the way if someone was presenting with a higher risk melanoma or one that had already spread. That could include folks like me, medical oncologists, to weigh in on what medical therapies may be useful or helpful or important for either in cases where something was removed but high risk. Perhaps there could be medical treatments available for reducing the risk of a melanoma coming back. Or for cases that are more advanced, medical treatments to try to help be the definitive therapy. Other folks that may be involved in particular ways, surgical oncologists or plastic surgeons or head and neck surgeons, depending on many factors like the location of the melanoma, the resectability of the melanoma, again based on staging. And sometimes a radiation oncologist may be involved in that process as well, depending on some specifics.
So when you're bringing this team together of all these different variables that can affect how your treatment is going to move forward for melanoma. How important is it to choose or the right oncologist? Like what should be somebody's process in finding an oncologist to treat melanoma cancer?
Yeah, certainly. So I think there's a lot of fantastic work being done by oncologists, out in the community, out in many different settings. And as people have had increasing familiarity with some of the treatment options for melanoma over the past 5 to 10 years in particular, I think people are very effectively able to get treatment for it in that setting. That being said, I think there often is also value, just like if you were going to, a surgeon for a specialized surgical procedure, you'd maybe want someone who was experienced and had done that procedure, several times. There may be value in situations where either you as a patient have questions or your medical team members or surgical team members have questions to get some additional input from someone who sort of lives and breathes the stuff, so to speak. We're pretty in the weeds in terms of not only what the current treatments options are, but also what's sort of on the horizon. And the reality is for oncologists everywhere, it would be the same, if I were thinking about lung cancer or pancreatic cancer or other things. These fields are changing so quickly, it's really impossible for any one person to keep up perfectly with every single one of these fields. We certainly try, but I think it always helps to have that, and that shouldn't be something that patients feel shy about. And like I said, we approach that in a very collaborative way, meaning that we work with, especially some of our patients come from long distances away. So we're always happy to provide a second opinion or even take over providing the care, but in whatever way makes sense for the patient and for their existing medical team.
Now, before we kind of dive into, the pathology part of it, a lot of times I think patients, when they're meeting with their doctors, they'll hear the terms adjuvant or neoadjuvant as far as looking at and reviewing treatment options while they're waiting to get a final pathology, which will ultimately dictate what's going to happen. Can you explain a little bit about what those terms mean and what are the different, options around those terms?
Sure, I'd be happy to clarify. This is certainly, even among what is dynamic broadly across the field, this is a particularly dynamic area within all of melanoma practice. And so, broadly speaking, this is really, we're thinking about cases in which someone is a candidate for surgery. So let me say that. That's broadly true. There are certainly some nuances here, but we're thinking about a patient who has a melanoma that likely can be addressed with surgery and or could become a candidate for surgery, surgical resection of their melanoma. So I want to say that from the get-go. The difference between neoadjuvant and adjuvant basically is the timing of where medical therapy plays a role in that process. Now, I mentioned to you that in some cases, medical therapies can help prevent or delay melanoma from coming back. And so if we think about what adjuvant therapy means, that means that is treatment given after some other definitive procedure, given as an adjunctive agent to try to mitigate the risk of that melanoma. So a classic scenario would be someone that has an earlier stage melanoma or even a stage 3 melanoma, but it's amenable to removal surgically. So that is completed, and then we would give some type of medical therapy, often immunotherapy or some targeted therapy. We can certainly get into that more later, but that treatment would be given with the goal of, again, preventing or delaying the risk of that melanoma coming back. That is different than neoadjuvant, where even if a surgery is planned, or you think a surgery could be planned, where some medical treatment is actually given up front ahead of that surgery being performed. There's been some very exciting recent developments in this field, especially over the past few years. We at Hopkins have participated in many clinical trials and have led the way in some of those studies as well. But even this year at ASCO, our big oncology conference, American Society of Clinical Oncology, this was one of the plenary presentations about neoadjuvant immunotherapy for melanoma. And the idea here is simply by giving a couple doses of medical therapy up front, perhaps people can actually have better outcomes than trying to chase whatever may be left, or by getting the immune system to go after any melanoma which may or may not be there after surgery is performed. You can think about it as potentially leaving a bigger target for the immune therapy to go after upfront. And so, what I think about when I think about cancer spreading, I sort of use the analogy of my patients of a fire. So if I think about a spot on the skin as being the fire, and we think about sort of fires giving off sparks, those sparks are what can go land in other places and produce other fires. And so if you think about adjuvant therapy, you're sort of trying to extinguish any flames that may be left, those little cancer cells that may have escaped that original area. On the other hand, the neoadjuvant is sort of saying, we're going to not only try to treat the fire where it is, but chase the sparks from the get-go. And there's some really compelling evidence to suggest that might be a better approach even than the adjuvant setting. Now, not everyone may qualify for neoadjuvant therapy. There's a lot of nuance there, but I'm speaking sort of in broad terms, but I hope that sort of helps everyone make sense of what the difference between those two approaches are.
Yeah, no, it does. And I know doctors kind of rattled those off in a doctor's appointment pretty quickly, and we don't really get a clear definition. And next, kind of the meat of our discussion is understanding our pathology, because the pathology is ultimately the roadmap to how a doctor, an oncologist, is going to treat your particular melanoma. What does it look like, and how are there questions you should ask or things you should look at when reviewing your pathology? I know a lot of times you're in your doctor's appointment, your doctor rattles off the pathology, you go blank, you have no idea, and then they might email you the pathology to look at a later date, and most people never even open up that email because it just looks just foreign, like a different language. So what are some key things to look at after that process? And then questions that you should ask your oncologist after you've had that information overload as they spew out your pathology, something that the patient should write down, take into their doctor's appointment, because you're not going to remember this, but after you hear it, your mind goes blank. What are some of the things you should address?
Yeah, great question. And pathology is certainly one and a critical part of the decision-making process. But I would caveat by saying it is still one part of it. And what I mean by that is it helps sort of form a large part of the picture. But certainly things like scans, things like other clinical factors certainly weigh into the final decision-making, when treatment recommendations are provided as well. What I would say is from the pathology report, I would add one other scenario that commonly comes up for us, which is nowadays the pathology is automatically released through the electronic medical record to a patient, and so the poor patients are faced with now this deluge of information, and it's just hard to make sense of, right? And again, this is one of those things you sort of have to be in the weeds of to sort of make heads or tails of, and even interpreting a melanoma pathology report compared to a lung cancer pathology report is going to look very different compared to a breast cancer pathology report. There are a few key factors. I can comment on what my eyes go to and what I try to convey to patients when I see a pathology report. In a melanoma report, we get lots of different facts and figures. A pathology report, we get again, I'm taking the example of someone who had a melanoma of the skin, for which a biopsy was done. In that scenario, we'll usually get a report that says something like, how deep did the melanoma go? It'll usually mention if there was any ulceration. And what that ulceration refers to is, did it sort of break the surface of the skin? That can sometimes be associated with a little bit, higher risk. It may comment on what the immune cells in the area are doing. It may comment on if any nerves were involved in that area, all of these types of things. And all of these connote sort of different levels of risk, potentially, to that particular melanoma. But a key piece of it is also the margins, the margin assessment. And this is something very important to be aware of. So the margin assessment is basically where the pathologist is looking at what are the edges of the biopsy. Usually it's just sort of pinpoints on the edges of the biopsy, and helping us understand, is there melanoma still present at the edges? And one of those edges also includes the bottom edge, the bottom surface. So a typical scenario may be, that the lateral margin is positive for melanoma, or the deep margin is positive for melanoma. These things are important because, for example, if a deep margin is positive, that may tell us that we actually haven't captured the full depth or the full thickness of that melanoma, right? And that gives us something else that we need to chase down. It also informs the surgical management of it, because depending on the depth of the melanoma is how it's actually determined, how wide of a margin needs to be taken when the more definitive excision is done. That's called a wide local excision, as some of you may well know. And it also dictates whether any lymph nodes are assessed as part of that surgery. So, for example, typically, you may see a cutoff of if the melanoma, we're talking on the order of millimeters, is 8 millimeters or 10 millimeters in thickness or more, then that usually warrants having a lymph node biopsy done as part of that surgical evaluation, because there's just a little bit higher risk that things may have gotten deep enough to travel to areas as I described before. Now, all of those parts of the pathology report really influence, again, like I said, our decision making in terms of how high risk something is and if medical therapy needs to be offered after any surgery. It may inform what type of surgical procedure is done. And but that is very different from someone who is presenting with melanoma that's not on the skin, that's already made its way somewhere else, whether that's a lung nodule or whether that's something in the liver, that type of thing. There, a biopsy is really more to confirm the diagnosis. Is this really melanoma? Because we don't want to be fooled by treating a different type of cancer. Of course, we want to use that as a definitive sort of approach to make sure that we're getting the diagnosis correct.
And I know
And
we
not
have
to
3
throw you
minutes.
a loop. I know, yeah. I'm sorry.
I know we
I
have
was just
3
going to
minutes
ask
left
really
here.
question, but we have 3 minutes, right?
Yeah, I would like to get
Now,
to a question about second opinions, and then I can see if we have time for the other questions from the group.
okay, great.
Sure. Let's see.
Yes, I can pose the questions about that. So we did
Oh,
get
please.
this question come up from attendees around second opinions. What are they for? When should you get one? Just providing a little more context around that and understanding how to navigate.
Yeah, absolutely. I think, if my family member were diagnosed with melanoma, I would certainly, want them to have a comprehensive team, a multidisciplinary team that's sort of putting their heads together to think about this case. As I mentioned to you, I think a lot of great care is provided in the community, and there's increasing familiarity among community oncologists in terms of how to effectively treat melanoma, and a lot of great work is being done there. I think it's never a wrong thing, and you should not take it as a sign that you are going to somehow sow, discomfort in the relationship or compromise your patient-physician relationship by sort of seeking additional second opinions as well. I think it's very much a part of what we do, and I think the important thing is, the goal is to keep you, the patients, at the center, right? And we're just trying to do right by you. And I think overwhelmingly, your physicians and your medical teams also understand that, and frequently they will also reach out, and we'll collaborate to come up with a treatment plan that makes sense. So I think a second opinion is something you should never feel shy about asking about, and it doesn't have to be because, and I don't think it should ever be taken as, you're not comfortable with the recommendations that you were provided. It's just a matter of getting some additional input, because these cases can sometimes be challenging. It's still a rare diagnosis at the end of the day, and I think reasonable people sometimes can disagree on what the path forward is. And so I think having some consensus, and if second opinion helps bring that about, I think that's a great thing to pursue.
Yeah, and the other thing I think to point out is most general oncologists see, for the most part, carcinomas, which are very different than melanomas. And I also think that team science, so to speak, is the best way to build your team for your oncology, because you love your local guy, you want to go there, he understands stuff, but a lot of times going to a melanoma center, just getting some reassurance and having them be able to work off each other gives you a leg up for sure.
I'm going to start the poll to close out for the group. I know there are some questions coming in. We will get back to you via email if we don't get to it right now, but I do have one question, Govind, that I think could apply to others, which is thinking about treatments. How long does it take to adjust to immunotherapy? In other words, if you're experiencing side effects, should you expect them to stay consistent, get worse? Can you talk to that?
Sure. And even before answering that, I'll just briefly take a step back because we didn't get to the treatment options in very much detail. I'll just quickly say broadly, we sort of think about treatments for melanoma in 2024 in three big buckets. The first is immunotherapy. The second are targeted therapies. These are oral medications that are leveraging the fact that there's some mutation that may be driving the melanoma to grow uncontrolled. And third, and a distant third in 2024 is chemotherapy as well. Among that, immunotherapy has really found a mainstay place in the treatment of melanoma because melanoma seems to be more responsive to this form of therapy, which sort of attempts to release the brake on the immune system a bit, so to speak, to go after the melanoma, more so than other cancer types. And your question about side effects and what can be expected with immunotherapy, the side effects of immunotherapy, we're learning a lot more about them, but it's still, every person's individual journey is quite unique with the side effects from potential immunotherapy. So immunotherapy broadly leverages the fact that the immune system can be a very powerful tool to fight back against the melanoma. But as it tries to do so, sometimes normal healthy tissue can get hit in the crossfire, causing inflammation in other areas, manifesting as some type of side effect. The side effect likelihood differs by if you're using one immunotherapy by itself or a combination, and if so, which combination. But the timing of side effects can also be very variable. We often don't start to see side effects until a couple cycles of immunotherapy or moving forward. But the reality is side effects can actually surface long after the discontinuation of these treatments and could potentially even surface years after the fact. It is less common for that to be the case. It's more common for it to happen, during active treatment after a few cycles, but it can actually happen at any time during the course.
Yeah, that's a good question. And I had just asked Govind that question a couple days ago. Is there any other questions that we should address, do you think?
There are a couple questions in the chat, but they're very specific to, a patient's condition. So we can follow up with those people separately. I have noted them and we will absolutely help you. That's what we're here to do. So thank you everyone for joining us. And again, if you have time to finish that post questions survey, they help us make sure that we can make these webinars as, productive and informative as possible.
Yeah, and I think it kind of leads us to another webinar to follow this up, which will kind of get into the actual treatment options, because I think that we could get through into some depth for about in 30 minutes, be able to cover that quite well. And it is, I think, really valuable to understand what those three different options are and how they play in terms of treating your melanoma.
Absolutely. I know we tried to cover a lot of ground today in just a very short period of time. Again, I'm very grateful for the opportunity to speak to you all today. I just want you to recognize, we know melanoma is a very serious diagnosis. I'm glad that there's increasing awareness. I'm glad that folks like Shannon and Cheryl and 1104 Health are putting together webinars such as this to increase education and awareness as well. But again, oncology is very much a team sport, and we're always happy to play our part in moving care forward for you all.
Great. Well, we appreciate you all hanging out with us today. We hope you have a great 4th of July weekend. And hopefully I can get Govind to come back in and really dive into the treatment options and what they need.
Awesome. All right. Thanks, everyone.
Thanks, everyone. Have a great day.